small number of people who sort of help guide the future. And I've always, I just do a lot of tasks when invited, but I try not to ever run for something, just invite me, I'll do it.
Well,
But
don't they say the best leaders are reluctant leaders?
is that what it is? Well, I was definitely reluctant. I was talked into applying, but then I ended up, or let my name be put on the nomination, and I was just elected to a 3-year term as leader, as one of the leaders. So it'll be, as I told some people, it means I'll still be doing this for the next 3 years then. I'm not retired yet.
Well, congratulations, Richard. It's excellent. And no better person could be in a leadership role than you.
Well, it's if anything, it'll hopefully justify to you folks here in Thailand that maybe I am, consider that somebody thinks I know something.
Thank you very much.
So, Dr. Manapad, should we begin?
Yeah.
Okay, we have the recording going, so we're ready whenever you guys are ready.
So tell me if this works. Do you see that?
Yes, we see it.
Okay, good. So what happened is we were previously talked about the history of transplant for myeloma, or history of management of myeloma, and it was basically 1990, or actually even 1980 to 2014 is where we got to. And so here I said I would divide this into 2 sessions. This will be, transplantation and now cell therapy innovations for multiple myeloma and how we're improving patient outcomes. What we reviewed last time was, in part 1, was the rationale for why autologous transplant in myeloma could be beneficial, the discussion of single transplant versus tandem transplant, the role of the impact of biologic therapies and how it all of a sudden started to positively impact even further than just autologous transplant, that survival was starting to go, into the 6-7 year range. We talked about the role of allogeneic transplants and how at one point it was felt to be primary, and now it's often 5th or 6th or 7th line therapy if we're going to offer it at all. We talked about the importance of continuous therapy in myeloma, which is the role of maintenance. And then when we finished, was the studies from right around the first half of the decade that just passed, looking at the issue of early versus delayed consolidation using transplant. Was it best to do it up front, or was it best to, say, control the disease and save it for later? And reminding then, where did we leave off? We left off at 2014. This is a slide I picked up from EBMT at the presentation last year at EBMT, saying that how myeloma has changed. And you could see from 1960, when melphalan was developed, to 2013, there was some innovation. But if you look at what's happened in the number of new drugs, and this isn't even all of them, that has come from 2013 on, it's continuing to improve the outcome of myeloma patients, and highlighted that there have been 18 agents approved for myeloma in the United States since the year 2000. This gives us a lot of options. Where we also left off was talking about the determination trial, which was a study saying delayed versus early transplant when lenalidomide maintenance was now the standard of care. And we're using upfront triple therapy for myeloma. So this is circa 2014, a randomized trial dividing approximately 730 patients or 720 patients who got upfront triplet therapy, stem cell collected, further on triplet therapy, and then rituximab maintenance versus you would be randomized to transplant, get post transplant, you get some additional RVD. I'm sorry, you get randomized to transplant, you get your upfront triplet therapy with lenalidomide, Velcade, and Dex. You get a transplant, you get some additional cycles, and then you go on Rituxan maintenance. And there were two studies. There was one in the United States. There were two parallel studies, one in the United States, one in France. The United States study was determined. Here's what it looked like, and the study was stopped early because there was an um, overwhelming improvement in progression-free survival for patients who got early transplant. And you could see that if you just decided to go on induction therapy with 3 drug therapy, not 4, but 3 drug therapy, not 2, 3, and then go on maintenance, half the patients were progressing by 3.5 years. But if you had a transplant, now we're up to, close to, median progression-free survival of over 5 years. Now, this is more than what we saw with the original CALGB 100-104 trial, which was the median progression-free survival was at 56 months. It's a year longer now. So this suggests that, we should still think about doing transplant early. Now, the same study, a similar study was done in France. And this was the French trial. The difference between the French trial and the US trial, you could see that the progression-free survival curves were a little longer in the US trial. In the French trial, if they did induction therapy with RVD and then maintenance, it was only 1 year of maintenance and then it stopped. In the US trial, the maintenance was continued until progression. So we did have longer time to progression. Both were statistically significant for improvement of progression-free survival with early transplant. However, when you look at overall survival, you could see there really was very little difference in overall survival still, because what we now know is the median overall survival for most patients with myeloma is 10 years. And you could see with follow-up, this was at the 5-year point. So this is at the 6-year point. So we don't anticipate, if there was a change impact in survival, it wouldn't necessarily be visible at this time point. But either way, it confirmed that early transplant still remains a standard of care. Now, there were something to be aware of is the risk of second malignancies. And when you looked at all second primary malignancies, prostate cancer, potentially lung cancer, breast cancer, there was really not a significant difference in cumulative incidence for patients who got RVD and then, transplant later versus those that got up front. What they did note is, again, not statistically significant, but an increased numerical number of secondary hematologic malignancies. And it's been, we know that myelodysplasia in AML is something we're not surprised to see, and they were seen here, but also there was a number of patients with Hodgkin lymphoma or acute lymphoblastic leukemia. At OHSU alone, we had 5 patients treated with myeloma who got lenalidomide maintenance after transplant and then developed acute lymphoblastic leukemia. So hematologic secondary malignancies is a consideration. Now, this was all based on where we were in 2015. Where have we come since? Well, there's been a discussion that, we really need to try and, if we're ever going to cure patients, what we have to do is get to an MRD or measurable residual disease level. We have to try and get as low as possible. And so we know we have 3 drug therapy, and we know what we get out of that. Well, can we improve it by going to 4 drug therapy? Can we add daratumumab to 4 drug therapy? So this was a study called the MASTER trial, which was, the goal was, can we enhance the likelihood of an MRD negative response using the next-gen sequencing of the original immune globulin rearrangement? Looking, can we get less than 1 in 100,000 cells? If we do 4 drug therapy upfront, a transplant, and then based on what we see, we're going to have adapted post-transplant consolidation and maintenance. We want to understand toxicity, we want to understand response, and we also want to understand the degree of the MRD negative state that can be achieved after transplant. And so this was the schedule. Everybody was planned to get a really intensive upfront therapy with daratumumab, carfilzomib, lenalidomide, and dexamethasone. So notice carfilzomib replacing bortezomib and daratumumab added. Everyone then, they were checked at these 4 points for the MMRD status. They got a transplant. They got 2 cycles of consolidation with 4-drug therapy, and then checked, and then up to 4 more cycles, then checked for MRD, and then they went on to Revlimid maintenance. So they want to say, how successful are they? Does all of this therapy make a difference? And what they showed is if you took all patients after standard induction, there's actually, with 4-drug therapy, 38% of patients could actually become MRD negative at a detection level of 1 in 100,000. If you went after transplant still has a role because you can see you can get up to now 2/3 of the patients are MRD negative after 4-drug therapy. And if you then went ahead to post-transplant consolidation before lenalidomide maintenance, you can now reach 80% of patients can reach that MRD negative state. And this is looking at these separate over here was what about the high risk characteristics? Do we have patients with, high risk abnormalities, which is amplification of chromosome 1q, translocations 414, 1416, 1420, or p53 deletion. And you can see that this MRD negative state could be achieved even for patients with 2 high-risk chromosomal events. They had then also deepened it and said, what about, well, that's 1 in 100,000. Can we get to less than 1 in a million? And you can see that now we see for patients with very high risk disease, very few patients, can achieve that. But if you take all patients, you can get a quarter of the patients down to a negative MRD negative state at less than 1 in a million detectable. So again, if you ever think you're going to try to cure myeloma, you have to be able to achieve an MRD negative state. They were saying from their master trial, they now know that they can achieve that in a quarter of the patients. And if you looked at by phase of therapy, if we look post-consolidation, 84% of the patients were in a stringent CR, CR of just standard CR, another VGPR of 12%. So what you have is basically 98% of patients got a VGPR or above. Now, this was exciting. This is changing how we think. And there are conclusions that 4-drug therapy up front, achieving an MRD negative space can actually, now they're addressing the question, do we really need to keep the Revlimid maintenance going if we get to those negative states? And this is being studied. So that was the master trial. There also was the Griffin trial. And this was a study that was published in Lancet Hematology, where this was, though, as the master trial was not randomized. Everyone was planned to get that therapy. This was a randomized trial of 4-drug induction versus 3-drug induction with the same goal of evaluating complete response and after induction, after transplant, and after, totally after maintenance. And, so again, now we're looking at 3 versus 4 drug. And notice the likelihood of getting a complete response or better was 83% of patients with 4-drug therapy, induction, transplant, consolidation, and then maintenance versus those that are, it's only 60% with 3-drug. Is this going to change the standard of care? Well, we'll show you that some people believe now that you should think about 4-drug therapy, and there are definitely people doing 4-drug therapy induction now for everybody. But absolutely, if you have somebody with high risk malignancy, high risk myeloma, that you really should be pursuing 4-drug induction and following this approach. What it looks like, if you look at the study from Griffin, overall survival, we still can rescue a lot of the people, but again, 3-year and 4-year overall survival is very short, in the world of myeloma these days. But if we look at progression-free survival, you can see it's already separating the patients who got 4-drug transplant and then post-drug therapy versus those that got 3-drug. And so again, will this translate to people living longer? It's going to take years to figure that out, but it's at least another step in the improvement of myeloma. So I just said that. So what was interesting is, what about Master versus Griffin? There was one major difference in the Master trial versus the Griffin trial. I just showed you these are 4-drug therapies. Master is a phase 2. Everybody gets 4 drugs, transplant and consolidation. Griffin, everyone gets 4 drugs. This is the 4-drug arm. Well, here in Master, remember they used carfilzomib. They used a 2nd-generation proteasome inhibitor, not Velcade, which is the 1st generation. And again, high risk, normal standard risk, really no difference between carfilzomib versus bortezomib. But if you get to multiple high risk cytogenetic abnormalities, there seems to be a trend that the more intense you are up front, the higher likely you were of getting a greater than a complete remission. Suggesting, again, people are translating this that we need to be more aggressive with our patients. And this is, again, so a paper that just came out from Natalie Callender with a group of patients, with a group of investigators from the Master and Griffin trial. They clearly looked and defined the progression-free survival by cytogenetic risk. And you can see the difference between carfilzomib-based and bortezomib-based therapy, especially in those high risk. This is surviving without progression, no high risk or one high risk. You really didn't need the intensive therapy. With 2 or more high risk cytogenetic abnormalities, there was significant difference in patients who were treated with carfilzomib versus those exposed to carfilzomib, versus those exposed to bortezomib. So it's something that we're going to think about, but without a doubt, high-risk cytogenetics are now demanding 4-drug induction therapy. I'm just going to say there's even now another trial that's being just generated now, the Optimum trial, where they're using daratumumab with cyclophosphamide, bortezomib, and dexamethasone, followed by transplant, and then post induction consolidation for 6 cycles, and then 12 further cycles of dara, bortezomib, and dex before you go on to maintenance. And it's 2-drug maintenance. This is for patients with high risk, newly diagnosed multiple myeloma. Really intensive regimen. Well, this is a study from England. What we see is, so far, this is short follow-up. Gordon Cook presented this data to say, compared to the 2 prior arms of a MRC, a Medical Research Council of England trials, that now we're at 2.5 years since treatment and randomization. This really intensive regimen has an 18-month estimate of progression-free of 80% versus 70 or even 50%. And again, looking at high-risk patients, again, when we see that, we may want to think about upfront treatment. And this is another way to look at this, is the impact of so this is a reminder of the importance of transplant in the era of novel agents. that pre-transplant, here's your depth of response. VGPR or greater is red, orange is greater than CR, and MRD negative is green. You can see that transplant still, post-transplant, that transplant has a role. So when people say you don't need to do transplant, if you're trying to get deep responses, transplant still achieves a major goal of deepening the response that can be achieved with upfront therapy. And is it important? That's the big question. Is MRD matter? And this is a study, a meta-analysis that came out of a group of investigators, Nicole Munchies from the Dana-Farber, and this is 93 publications in that meta-analysis. And what you can see is, if you look at the likelihood of, now we have 12-year follow-up is being measured on this study. If you look at progression-free survival versus overall survival, patients who are MRD negative have a superior outcome compared to those that never gain MRD, negative status. Now, what's the criticism here? Well, it's a criticism just to declare it. Why do they have MRD negative status? Well, we just showed that intensive therapy is going to get there, but basically, there's some disease that will always be more sensitive than others. And if you have intrinsically resistant disease, you will not get that MRD negative status, and you will not have as long remission status, and you will not have as long overall survival. But again, that's dictating who has resistant disease. But if you actually try hard to get someone to an MRD negative status, they can achieve and expect to achieve longer outcomes. So where does that leave us here is how do we treat patients now? And just as a reminder, how do we have new patients? We have a whole host of approaches that we could take, variant IMiDs, variant proteasome inhibitors, with or without transplant, with or without, whatever maintenance, however you put it. What this was just showing, this is just a schematic to show you that there are so many different approaches in early phase. But notice the biggest part of take-home message is your best outcome is up front. Because the median progression-free survival is 4 years in this review. Once you have second-line therapy, you have many, many options, but your median progression-free survival drops from 4 years to approximately 1 year. And then what happens when you progress, and then you go to third-line therapy, your progression-free survival, you still have many options, but your progression-free survival is now 6 months. So you have a declining benefit as you progress in lines of therapy. And that basically impacts how we think of myeloma today, which is now the role of CAR T therapy. So this is a case, I gave a talk, 6 months ago, and we actually made it a little bit case-based. And this is just to remind you, this is the case presentation, in effect, that shows how we manage patients, and it actually follows this sort of sequence when you actually look at first line, second line, third line. This was a 60-year-old young patient. She has an advanced ISS stage 3 disease. She has the amplification of 1Q, but also the 14-16 translocation. So she counts as high-risk disease. She presented with renal insufficiency with a creatinine of 2.9. So she's a B. She's stage 3B. She's got hypercalcemia. It was reported as having hypercalcemia, and with light chain disease, beta 2 was 6. So she's felt to be ineligible. She got 4-drug therapy with daratumumab, lenalidomide, bortezomib, and dexamethasone, and then went on to bortezomib, lenalidomide maintenance, and gained a VGPR status, and then went on to stem cell transplant and Wnt transplant. She went from VGPR, she remained VGPR post-transplant. So again, we point out, this was a question to say, how often do you do marrows? How often do you check cytogenetics? Cytogenetics are usually pretty stable when you look at somebody with new diagnosis to the time you're looking at first line therapy. You usually don't see cytogenetic progression. You can definitely see cytogenetic progression in second line. And characteristic, this may be what you see in newly diagnosed myeloma. These are the characteristics that'll define a high risk myeloma patient. Most people do not do high risk gene expression profiles, just for the point. That's this test. You can often do it off of cytogenetic in fish. MYC translocation in the absence of a defined partner, some people will also consider high risk. Plasma cell leukemia when you have greater than 5% plasma cells in circulation, or soft tissue disease. When you relapse, when you need second line, it's, what defines high risk? Well, if you have early relapse after primary therapy, or if you gain a new mutation. And those new mutations, 1Q is very commonly gained, as is P53. We don't see a lot of gaining of a 1620 or a 1416. I'm sorry, 1420 or a 1416. But these often will be gained in second line. So when you have relapse, confirmed relapse, it's worth repeating the evaluation. Or if you now have soft tissue disease. And so going to this case, the patient had a transplant, was on Reb maintenance, but after 2 years, started to present with light chain elevation, hypercalcemia. Light chains are now 340 per deciliter or 3,400 per liter. M protein is up to 5, and has some renal insufficiency, so they need second line therapy. So they basically started daratumumab, carfilzomib with dexamethasone, and got a very good partial response. But then what happens with daratumumab, you basically keep people on maintenance until progression. Some people would do a second transplant. Some people would say, I'm going to just keep you on that regimen, because that's how the Castor and Pollux trial, those were the first 2 daratumumab trials that came out for patients that relapse after transplant. And they recommended continuing daratumumab-based support until progression. And what happens is 2 years after disease, she now has yet another relapse. Beta 2's high, light chains are back high, and she has new skeletal lesions that weren't there before, no soft tissue disease, and she wants to know what to do. And so everyone sent her and said, think about CAR T therapy. But now this is going to be second relapse, third line therapy. So we're going to talk about that. So what do you do? So this is just, like I said, we're addressing modern day myeloma management since 2014. And you have to mention CAR T therapy. The main drug used, the main target is B cell maturation antigen, or BCMA. There are two CAR T products approved: idacaptogene vicleucel and ciltacabtagene autoleucel, and they are going to see the target molecule right here. So this is the SCFE, the chimeric molecule that'll see a target BCMA. We also have bispecific T cell engagers or bispecific antibodies. So we have teclistamab, which sees BCMA. We also have elranatamab and alnuctamab. We don't use this. Elranatamab is our second choice. We use teclistamab that sees this agent. And you also have a drug conjugate, belantamab. This is a immune conjugate that sees a toxin, it carries a toxin to the myeloma cell. This has a lot of toxicity. You have to do it, manage it with an ophthalmologist because there's a lot of corneal keratitis in these patients. I've managed this. I've had fantastic response with belantamab, but I've had patients after two doses, they basically couldn't see well. Their eyes were totally blurred. They had corneal keratitis, and their vision was lost for 2 months. And then when that happens, you take them off drug, and then the disease progresses. I think the FDA has they took belantamab off the market. They've re-entered it at a lower dose schedule now than what was originally done. But let's talk about CAR T. You guys, so we've talked some CAR T before, but just to tell you again, there's two companies. I said idacaptogene and ciltacabtagene are FDA approved. The first study was the KARMA study was testing idacaptogene. You have to have had three or greater prior lines of therapy. You have to have been refractory to proteasome inhibitors, IMiDs, and also failed an anti-CD38 antibody. You could not have had a prior BCMA therapy. Patients were identified. They would undergo a white cell collection that would be sent off for manufacture of the CAR T product. They would then receive some sort of therapy to bridge them, and then they would get chemotherapy focused at immune suppression. So when the CAR T was administered, the CAR T would have the best and most optimal opportunity to grow in the person and expand to fight off the disease. If we looked at patient characteristics, there was 128 patients. The primary endpoint was overall response rate. A third of the patients had high risk cytogenetics. Half the patients had over 50% plasma cells in the marrow when the cells were infused. That's felt to be a high risk characteristic for having complications. 40% had disease in the soft tissues. 95% of the patients had had a prior transplant. If we look at the overall response rate, it was 3 doses. It was a 3-dose schedule. What they showed is, and this became 450 times 10 to the 6th is now the standard approved dose, the target dose. There was an 80% response rate with 40% complete remission and stringent complete remissions. And yeah, so excellent overall response rate. Sorry. Yeah. Median duration, importantly, you can do something, but remember, once you run beyond third line, we expect a response rate of less than 6 months. What they showed is the median duration of response was approximately 1 year. So they more than doubled the expected disease control rate. Now follow-up was 2 years. And importantly, the median time to first response was 1 month. Because basically, you gave the CAR T, you supported them for a month, and then you checked their myeloma labs or myeloma bone marrow, and you showed that if you're going to respond, it's pretty rapid. And this is what it looks like for survival. Here's what it looks like for complete remissions and stringent complete remissions was ultimately, by the way, sorry, one comment. This is all patients. You often deepen the response. You could sometimes treat a patient and have a PR at day 30, but you'd go on to a CR. So if we look at all responses, a third of the patients had a CR or better, and a VGPR of 20%, partial response or 20%. So these patients didn't do as well. So 50% of patients were CR or VGPR. And if you look at progression-free survival, though, again, it is not a cure. It's not dropping down. Maybe you could see, do I believe this? This is only 2 years, and almost 90% of the patients had progressed. So it's a short-term intervention, Now, is it worth it? Well, the patients think it is because up until now, they've been on continuous therapy, weekly, biweekly, monthly in the doctor's offices. Now, once they have a response, if they're in this category, they're coming in every 3 months only. Were there toxicities? There were cytopenias, which is not surprising. Infections were seen. You could see both viral infections as well as bacterial infections in about 25% of patients. The cytokine release syndrome was seen. 84% of patients developed fever or maybe mild hypotension or mild hypoxia, but only 5% of patients had grade 3 or 4 cytokine release syndrome. Neurotoxicity was actually pretty low with this at only 18% and 4% advance. There were 3 early deaths, and that was due to hemorrhage or aspergillosis, and 1 patient with advanced grade 5 cytokine release syndrome, some late infections. What does it look like here? Again, oops, never mind. So I just went back that. Sorry. That's what I was just showing. This and then this way. So that was the ida-cel data. Then we had cilta-cel, ciltacabtagene. Similar criteria. You have to have had a prior proteasome inhibitor or anti-CD38 antibody. You have to have had 3 or more prior lines of therapy, or you had to be double refractory to here. So you could actually enter a little early without necessarily having a prior anti-CD38 antibody. They had their share of high-risk cytogenetics, 25% of patients. Extramedullary disease was only 13% of patients. This patient population was a little less invested, less involved. They did have, remember, it was 50% of patients had plasma cell burden over high plasma cell burden in the marrow. Here it's only 20%. Still also prior auto transplants, 90% of patients. A little bit better patient population. What did they see? They actually had also excellent data. But now, instead of a median progression-free survival of 9 to 12 months, this is updated. It's up to 35 months. That's from the original CARTITUDE-1. By the way, a lot of people want to sit back and say this is the better drug. I can't say that just because it's different patient populations, not randomized up front. But again, instead of a 50% CR, VGPR, it's over 90%. It's with 82% stringent CR, very deep responses with ciltacabtagene. Now this is important too because we now, as I said, some people are getting bispecific antibodies. A number of patients were getting on clinical trial at the time. A number of patients had gotten the immune conjugate with the belantamab. What happens if you got prior BCMA therapy? So this is CARTITUDE-2. This is an important take-home message, which is right here. Remember the response rate was like close to 90%? If you had patients who had prior BCMA exposure, the overall response rate now drops to 60%. And it didn't matter if it was a bispecific antibody or immune conjugate. The median duration of response is now no longer beyond 2 years, it's down to a year. So what does this mean? Well, one, it tells me if I, at least on face value, if I'm going to take somebody, I have a choice of a bispecific antibody or a CAR T. Maybe I'll do a CAR T first because the data tells me I'm more likely to have a longer response. What it doesn't tell me is why did the patient get the bispecific or the immune conjugate first? Maybe their disease was so bad they needed something to cool them off before they can get the CAR T, and that's why they went to that that bispecific. That's why they got the BCMA therapy first, and they just had more aggressive disease, and they were destined not to do well. Again, without prospective studies, I can't really tell you. I can hypothesize, but when you look at the data, these are the data what everyone's looking at. This is 60%. This is 90%. People are going to say we should do that first. We're going to do a CAR T before we do a other BCMA directed therapy. Now, those data were excited. Those data were for very advanced patients. What about patients with disease that was less advanced? And so there's two studies. KarMMa-3 is idacaptogene again. Both these studies were published in the New England Journal in 2023. This was they're randomized. They're not non-randomized. They're randomized against standard of care. And so here, these were patients who were second or third line, but they did have to have prior daratumumab. And they're randomized to one of these salvage regimens or randomized to CAR T. Primary endpoint was progression-free survival and a host of other secondary endpoints. There's other patient characteristics. I would just say they were relatively well balanced. And in this case, though, what we showed was, again, earlier patients, prior exposed IMiD, proteasome inhibitor, and anti-CD38 antibody compared to standard of care, your progression-free survival was markedly enhanced when you got CAR T over another alternate triplet therapy for which CAR T would be put off later. An overall response rate was 70% versus 40%. In stringent CR or CR and stringent CR was 40% versus 5%. CAR T then becomes approved. Idacaptogene was then approved for earlier application. Well, not to be left out of the mix, ciltacabtagene also ran a study compared to in randomized to standard of care. Similarly, upfront, 1 to 3 prior lines of therapy. Again, an important difference. And I just point this out because, you'll see the advertisements. Our drug has longer benefit, but you have to understand this was for patients who are lenalidomide refractory. So they could be 3-drug therapy, auto transplant, and Revlimid maintenance, and then be eligible. They did not have to have prior CD38 antibody. So you can also see here how many patients got priors, had prior daratumumab. Only a quarter of the patients. In the prior idacaptogene study, it was mandatory that they had to have had prior exposure. So here, again, a little less exposed patient. And again, the CAR T was superior to standard of care in the progression-free survival, in overall response rate, and importantly, in now MRD negative at 1 in 100,000. And the median duration of response at 12 months was 85% versus 60%. And the 12-month duration of response, and the median was 16 months with the standard versus not reached in cilta-cel. So coming out favorable. Similarly, they did have this is the safety grade. I will point out though that if you look at the neurotoxicity, was 20% any grade, 3% advanced with CAR T, but they had some unusual neurotoxicities with cranial nerve palsies and Bell's palsy with a cranial nerve 7. There also were patients who had a Guillain-Barré-like syndrome or a long-term Parkinson's. So that's not where it stops. I think I will stop here in about 2 minutes. There still are more CAR T therapies coming. There's some studies that are out there. I don't have a lot to say on this study, except it did have high CRS and high, response rate. Novartis developed an agent that looked quite effective. We just heard, this is very short follow-up, great response rate. We heard just about a month ago that this Novartis was not continuing this, agent, that the competitive market was going to make it hard to compete, bring a new drug in without any specific advantage, and they were discontinuing this development. However, CAR T, DD, BCMA is a really unique product. We participated in this trial, and at ASH, there's Maziar, so there I am contributing. This is the drug called now an anitocabtagene autoleucel. Now, what's interesting about this is, so this was run by a company called Arcellx. Arcellx has just been gone into a big partnership with Kite Therapeutics, which has produced Axicel and Brexicel. So this is your standard. This is idacaptagene with an SCFV. This is ciltacabtagene. One of the unique aspects of ciltacabtagene is it's bivalent. It's got two different SCFVs to interact with the target. This particular product, anitocabtagene, is a synthetic product. They have identified a small molecule that will interact with BCMA. It's much smaller. By being that much smaller, it has less of a strong binding. So it's fast. It's got a fast delivery of a signal. But what it does is it doesn't cause chronic tonic signaling. So we think it's going to be less likely to give a T cell exhaustion because it has now a fast off rate. So it binds, delivers a signal, and drops off, goes to see another, and goes to see another. And it's hypothesized that this is going to be ultimately a superior agent. Well, this was the phase 1 study for patients who were beyond fourth line therapy. Importantly, the median progression-free survival is 2.5 years at almost at the 3.5 years. So again, that matches ciltacabtagene. It's better than idacaptagene. Median overall survival not reached. So what they've now done is do a phase 2 study. I'll leave the slides. You can look at the slides, but it's taken patients that are going to be earlier. So 3 lines of therapy. They had to have been refractory. But what they're going to do now is look at if we apply it at not 4 lines of therapy beyond, but 3 lines of therapy, can we have a better outcome? Well, the data were, again, high risk cytogenetics 40%, penta-refractory 40%, prior transplant 3/4 of the patients. Here's the data. They also had a stringent CR or CR of a 62%, VGPR 80%, overall response 97%. Very similar to ciltacabtagene. By the way, these are the data. These are the slides from ASH because I just got them last week. It was presented. Notably, 93% of the patients reached MRD negative status. And importantly, and maybe even more importantly, this is the overall survival, progression-free survival at 12 months is nearly 80% and high survival rate. When we looked at toxicity, cytokine release syndrome was seen commonly as grade 1, minimal grade 2, one grade 5 patient. That patient developed HLH. But we looked at neurotoxicity. There was almost no neurotoxicity. I thought I had that. Maybe I left it off. That's part of the conclusions. Yeah, so there was no delayed or no non-ICANS, no Parkinson's-like activity, only 9% ICANS. So a promising agent. seems to have an excellent safety profile. It is being that phase 2 data is a registrational trial. They will be moving forth to the FDA. So where are we now with the NCCN guidelines, the National Comprehensive Cancer Network for myeloma? This is now showing us where we are from. Remember, I was saying this is picking up the last, showing where we are in the last decade. We now have multiple BCMA specific agents. We have multiple approaches to treating relapsed refractory disease. These are the preferred regimens, are CAR T therapy or bispecific antibodies. And I don't even mention talquetamab, which sees GPCR5D, a second antigen. Now, it's a hard drug to deliver. It's got a lot of toxicities, but it's even a bispecific antigen. So once you have a BCMA, you can come up with an alternate agent. This was originally for beyond 4 prior lines. Now we have it from April 5th, April 4th, idacaptogene, April 5th, ciltacabtagene for much earlier, 2 or more lines for ide-cel, 1 or more lines for cilta-cel. These other regimens can be considered. I will tell you, we frown currently on bendamustine because bendamustine I've always used before. It's a great drug for treating myeloma, but bendamustine is also very hard on the lymphocyte pool. And if you're going to ever use bispecific antibodies or CAR T, bendamustine really depletes your lymphocyte pool and you lose some of the benefit. Selinexor, we like the drug. I like the drug. High dose and fractionated cyclophosphamide I like. You also can use venetoclax if you've had a patient who has only if they've had the 1114 translocation. The one thing about selinexor, the FDA approval was for twice a week. Almost nobody can tolerate twice a week because of severe nausea. We've developed a once a week regimen, sometimes adding it to carfilzomib. And belantamab is now available again, but in selected patient population. But that's but at a dose change. So that's my update. I just, we had this. I always promised that I would finish part 2. I was reminded yesterday that we had this presentation. This was on the schedule, and I guess the last time we had a deferral from your team, and I wasn't sure if we were presenting or if they were presenting. Turns out I was told it was us, so I just organized this since yesterday. So it's not as clean and perfect as I would normally like, but hopefully it was instructive in showing you the future of myeloma management for all of our patients, as long as we can get these agents to the patient. And I know you're working very hard in Bangkok right now in the ability to get these agents for your patients. And I hope that we can continue to help support that effort.
Thank you very much, Richard, for your very informative talk. So I think that with the advance of the myeloma treatment, myeloma can be probably cured in the very near future.
I agree.
But yeah.
Well,
But
the
I think,
combination of 4-drug therapy, getting to an MRD negative state, and then with these, I didn't mention it, but there's a trial coming out that's starting to look at CAR T for consolidation after auto transplant. So we'll take advantage of the induction, take advantage of the auto transplant, which we showed that auto transplant enhances the likelihood of getting MRD negative. And then they're going to take CAR T afterward, and we can see what a high degree and high depth of response we get now. So I agree. I think we are going to cure myeloma.
But our problem here in Thailand, I think, is the expense of the noble agents.
Correct.
Therefore, I think the personalized medicine is very important, so that we can identify some high-risk patients and some standard risk patients who can get just only standard and affordable treatment. And for those with high risk, will get the sophisticated and further more effective treatment. right?
Yeah, no, and I want to say to you, I 100% agree. I'm very sensitive to that. And, when going to Thailand, I applaud you for your efforts to try and develop, point of care manufacture. What I still hope is that the off-the-shelf CAR T products that are going to be generated from either iPS cells or potentially, universal donors, that if they come forth, they should be able to generate master cell banks that the price should come down by several $100,000. Whether a company will do that or not to be determined, but off the shelf products where you don't have to personalize that individual product that will be literally in your pharmacy should be a lot cheaper. And so far, the off the shelf products in CAR T have not yet been realized. I think there's a company named Allogene. I think they may be the furthest along. We're going to be entering a research study with Allogene, which is, looks very exciting. But I'll talk about that at a later date. But, off the
Okay.
shelf still may be the solution to making CAR T available. And honestly, as you started with my congratulations, one of the things I pointed out in my short blurb, my 200-word blurb, is that my focus over the next 3 years working with ASTCT is we need to make these therapies available to as many people as can get it. So we have to make them affordable. That definitely
Thank
is
you.
my mission.
Thank you. Thank you. Thank you very much. So thank you again, and I wish you Merry Christmas and Happy New Year, and wish everybody too. Thank you very much.
Yeah, and I thank you all for
ค่ะ
taking the time,
Mhm.
to listen, and I look forward to continuing this. I think we're going to reorganize.
we
We're going to
got the
start.
budget approved.
What's that?
Budget is approved 2025.
Oh, fantastic. Well, I was going to
Yes.
say is I look forward to next year where we're going to try and spend some more time now expanding not just the transplant and the CAR T, but talking about novel therapies and novel approaches to are these other diseases that we can. The goal is to cure patients with lymphoma, leukemia, myeloma. We want to cure all these diseases. So thank you for hearing that
Thank
too.
you. Thank you. Thank you.
I'm
Thank you.
I'm excited for the future.
Us too, Prof. Happy New Year and Merry Christmas to everyone.
Thank you.
Bye-bye.
Thank you, Dr. Monica.
Same to all of you.
Thank
อัน
you.
นี้
Bye
ค่ะ
bye.
บ๊ายบาย
Thank you.
Don't
Happy
forget
New
to
Year.
send the recorded video to me, Leah.
Okay,
Thank
we
you.
will. Thank you. Thank you,
All right.
Richard. Happy
All right.
holidays.
Bye bye.
Bye-bye.
Hi, Parani.